Sir, is it okay now? Sir, your voice is not audible.
Yes, thank you, Dr. Deepa. It's available now.
Thank you.
Yes. Yes, dear friends, sorry for the initial small interruption. I love to write and talk. Okay, so shall we begin? Or we need to wait for the participants?
No, no.
Okay, okay. So here, when we begin our this small presentation, so now let us understand, for example, in human body, heart is present. Now let us imagine, now here we have the heart. Heart is in a place like, for example, whenever we talk about cardiovascular pathology, whenever we talk about a cardiovascular pathology, is it important for us to examine only the heart or the entire body? It is important for us to examine the entire body. Why entire body has to be examined? Because heart is present in the chest, okay? But the blood is being circulated to all parts of the body. The blood is being circulated to all parts of the body. So whenever there is any pathology related to the heart, what happens is this blood circulation is going to be minimized. Most of the situations, the cardiac output is going to be altered. Or whenever there is any problem in the heart, that blood can also carry that pathogenetic material to every part of the body. Thereby what happens? We may get different signs and symptoms in the periphery. So cardiovascular system examination is incomplete without the examination of the periphery. So whenever you start trying to understand different pathologies of the heart, most of the time we get maximum findings in the periphery. These peripheral findings are star marked findings. I will give you several examples here. And then it is also important for us the precordial examination. Now, precordial examination means it is only the chest which is overlying the heart. The precordial examination itself is generally considered. Most of the time when we talk to the students, they will start explaining about the precordial examination under 4 headings. One is inspection, palpation, percussion and auscultation. These are the 4. Percussion is having less importance in the cardiovascular system, and it is also disregarded because of the sensitivity. One thing is that percussion can be a little problematic if you are not so experienced. They say that aggressive percussion on the chest wall sometimes can release the thrombi into embolus. So that's a risk is there. So if you read the modern textbooks or the new editions of the textbooks, they give maximum emphasis on inspection, palpation and auscultation directly. But this percussion is of great value when it comes to respiratory system examination. So my session today, we will be dealing exclusively on this examination, that is the periphery. Tomorrow's session, I'll be talking more about the precordial examination. I'll be going rather at a comfortable speed, so that if you have any questions in between, or if you feel something needs re-emphasis or explanation, you can very well stop me and ask me. So I think with this, we will start our session. So now, when it comes to cardiovascular system, okay, we have to understand that it is exclusively an examination of the heart. It is exclusively an examination of the heart, but it also includes examination of the face, neck, and hands. Face, neck, and hand examination becomes very, very important before coming to the conclusion of cardiovascular pathology. So again, when it comes to precordium, we have to inspect, we have to palpate, and then we need to auscultate. So now, whenever you start any examination, now this particular whatever I am talking to you, I am speaking on a subject which is called Ascii. OSCE refers to objectively structuralized clinical examination. Now, why I am taking this particular cardiovascular system examination on the basis of OSCE, if you ask me, my answer is it is objective. First of all, it is objective. What is the meaning of objective? Now, most of the times you see that even sometimes teachers do this. Actually, you need to do this examination this way. If you ask them why it is supposed to be, don't know. My teacher told me like that. Okay. So when you say that my teacher told me, I believe like this, it is like this according to me, that means you are adding subjectivity. That means you are adding subjectivity. Today you learn in Kerala, you come to Karnataka, or you go to Dubai, or if you practice in America, wherever you go, your method of examination should not be changing. That's why your method of examination should be objective. Please remember that it should not be subjective, but it should be objective. It should be accepted wherever we go. That's why it is called objective. Okay, and it is structuralized. That means it is properly framed. Why it need to be properly framed? For example, I'll ask you a question. I know that all of you are muted. You don't answer in this kind of sessions, but still, just an introspection to yourself. For example, if I ask one student, what are the things you are going to inspect on the chest? And if I ask the next student the same question, are you both going to answer in the same structure or a different structure? You people are going to answer in a different structure. Please understand this one, because some people may say, I would like to look for scar first. Somebody will say, I am going to look for any swelling. Some other may say, no, pulsations are very important. So I'll start with pulsation. So there is no structure. That's why OSCE is designed in such a way that it will help you to structuralize your examination in a standard format, so that whatever you are doing, your friend also does the same thing, so that you never tend to forget anything. Everything will fall in the same place. Okay. So this is objectively structuralized clinical examination. The first step in the OSCE for cardiovascular system is, the first thing is you need to clean your hands. Before you come for examination, you need to clean your hands. When I say wash your hands, nowadays you need not wash. At least sanitizing your hands before approaching the patient is very, very, very compulsory. Don't think that it is COVID time, that's why I'm teaching you this one. No. Elsewhere also, whenever you are approaching a patient, the first thing you should do is wash your hand. And whenever you finish the examination, what is the last thing that you're doing? Again, you're washing your hands. There is an importance for this too. Before you're washing your hand, and afterwards also you're washing your hands. First, we are washing the hand because we don't want to take any infection to the patient. Last, after finishing the examination, why we are washing the hands? That is, we don't want to bring anything from the patient. Okay, so it should be very, very careful, because we don't see only one patient. We go from patient to patient. So that's why we need, once the examination is over, we need to sanitize our hands, or we need to wash our hands thoroughly, so that you don't take anything from the patient. Okay, that is the first step in the cardiovascular. Then second important thing is, you need to introduce yourself to the patient. This is a classical habit, which in India, most of the time we don't practice this. You know, we go and ask patient's name, but we don't tell our name to the patient. It is very, very important. You should start like this. My name is Dr. Raja, and I am here to examine you. Okay, so that is the correct way of representing yourself in front of the patient. So after sanitizing your hands, when you approach the patient, please introduce yourself to the patient. After that, you just have to clarify the patient's identity. Asking the patient's identity is wrong. Asking the patient's identity is wrong. For example, if you say, you know that bed number 3 is, patient's name is Biju Matthew. So you don't have to go there and ask the patient, what is your name? You just have to ask, are you Mr. Biju Thomas? Are you Mr. Biju Thomas? That means you are clarifying the patient's identity. Once you clarify the patient's identity, you need to explain the procedure. But please remember, here you don't have to explain the technicality of the procedure, but you need to tell him that today I am here to examine you. My examination may include, sometimes I need to change your position. Like sometimes you may have to stand, sometimes you may have to walk, sometimes you may have to lie down. Okay, and my examination procedure sometimes may create little bit of pain, but still this is I am doing in order to understand what is the exact pathology with you. So the last part of your explanation is obtaining the consent. After explaining everything, you should ask, can I do so? Can I do so? That means you are taking the consent. So the first step, whenever you visit the patient, you have the 5 important points. The first point is you need to sanitize your hands. Second, you need to introduce yourself to the patient, clarify the patient's identity, and then explain the procedure, what you're going to do in a brief manner. No, don't have to use technical terms. Just explain what is the different types of things that you're doing with the patient. Finally, obtain the consent. That is very, very important. And that is a classical form. Now, coming to the second step in our examination. Now, you see this here, we are asking the patient to sit. Now, you know that every examination requires a position. That is the first thing I actually tell my students, that what is the position the patient should be. When you are doing a respiratory system examination, what is the position? For example, if you are examining a hernia, what is the first position the patient should be in? Patient should be in standing position. Similarly, when you are doing a cardiovascular system examination, patient should be in a position, that position is called Fowler's position. It is called Fowler's position. What is the meaning of Fowler's position? See this, the trunk is making a 45-degree angle with the rest of the body. If you want, you can note down this one. When the trunk is making an angle of 45 degrees with the rest of the body, this position is called Fowler's position. So this is the one. So now you have every hospital has the head end of the bed and the foot end of the bed. So head end of the bed need to be elevated at 45 degrees so that is the best comfortable position for doing the cardiovascular system examination. So please remember, this is a good question in the exam also. What is the correct position for the patient to be to do a cardiovascular system examination? That is Fowler's position. Now, once the patient is sitting in that position, he need to be undressed. He need to be undressed. That means the patient should be covered only specifically, but rest other areas he should be uncovered. Now, the best uncovering for cardiovascular system is uncover him or expose him from waist above. Expose him from waist above. For females, we may not be able to do this. So this is called comfortable exposure, where the patient is also comfortable and the physician is also comfortable for examining. So that's why comfortable exposure is practiced for females. But in case of males, it is exposed from waist above. That is always beneficial. That is always beneficial. Okay, remember this one. And next point is you have to observe the patient. When you are observing the patient, don't stand close to the patient, but you need to start observing the patient from the foot end. Observing the patient from the foot end is very, very essential, because you are supposed to not create consciousness. The patient becomes very conscious. If you stand very closely and start looking at his chest, he will not be comfortable. Okay. At the same time, there is something called as precordial heaving. No, there is something called parasternal heaving. Now, parasternal heaving, you cannot observe from a closer distance, but you need to go to the foot end of the bed, so that what happens, you observe the chest bilaterally. Both sides are simultaneously observed, so that if there is any lifting up of the precordium with every cardiac impulse, then the parasternal heave can be observed very carefully. So observing the patient is important, but you should observe the patient from the foot end of the bed, but not but not standing at his head or at the chest. It's very, very important. And remember, somebody, I always tell this one. So when you are counting the breath sounds. When you're counting the breath sounds, what do? You keep something on the chest, and movements are perceived. Okay, and all this time you are staring at the chest. Just imagine if the patient is a male, at least is okay. But if it is a female and a male student is examining that, if you are staring at the chest, naturally it gives lot of uncomfort to the patient. Let me tell you, because whatever you do, we are not supposed to cause any kind of unnecessary discomfort to the patient. That is the reason we need to practice this. I always tell my students, when you are checking the pulse, how much time we should check the pulse? Pulse should be checked for 1 complete minute. And respiratory rate is also checked for 1 complete minute. So what I tell is, after you finish the pulse rate, after you check the pulse rate, don't leave the hand. Hold the hand like that only. And now, indirectly, you just look at the chest of the person, so that he or she thinks that you are still checking the pulse. Okay, and then you can simultaneously count the respiratory rate also, so that you can actually reduce the discomfort from the patient. Okay, another important thing is, standing at the foot end will help you to understand the parasternal heave much better. So that's why you need to stand at the foot end of the patient. And remember, whenever you are examining a patient, you need to have a bystander. The bystander, also called as the shape of one. And this particular bystander is required. For example, when a male is examining a female, you need to have a female bystander with you. Okay, so this is very, very essential. So you are observing from the foot end of the bed, and you need to note certain things. You need to note down certain things. The first one is, check whether the patient is comfortable. This is very, very important, because many a times, if the patient is uncomfortable, it is because of breathing difficulty or it is because of pain. These are the 2 important things. So today we are not discussing anything else, only cardiovascular system. So either it is because of the breathing difficulty or because of the pain. Most of the patients will be uncomfortable. So first you should address to those things. Okay, so first find out whether the patient is comfortable or not. Next important thing is, look whether the patient is having any cyanosis, whether he is cyanosed. Now, when I speak about cyanosis, I am not going details about that. You all know that cyanosis is 2 types, peripheral cyanosis, another one is central cyanosis. So now we need to also have an assessment whether he is having peripheral cyanosis or central cyanosis. Central cyanosis is so simple, only the lips and the tongue, tip of the tongue and the lips. If there is any cyanosis that is involving the lips and the tip of the tongue, that's called central cyanosis. Now, whenever there is a cyanosis, we know that the patient is having more amount of reduced hemoglobin in circulation. That is very important and essential. Students get confused. More reduced, no, 2 exact opposite. There is increased concentration of reduced hemoglobin in circulation. Reduced hemoglobin means the hemoglobin which has already detached from oxygen, now it is binding with carbon dioxide. So more amount of reduced hemoglobin, more than how much? 5 grams. More than 5 grams of hemoglobin, which is reduced variety, then the patients tend to experience something called central cyanosis. Peripheral cyanosis you can see in the ears, face, okay, and extremities. All these things is peripheral cyanosis. Peripheral cyanosis, several reasons are there. Cause may be in our body, cause may be outside the body. Outside the body means the patients may be exposed to cold temperature. They can also have arteriovenous fistulas. They can have that problems. Okay, so these are the major. Central cyanosis, either it is pulmonary cause or it is cardiac cause. Cardiac cause, the most important cause is heart failure. Then occasionally even congenital heart diseases also can produce cyanosis. You know, congenital heart diseases predominantly are acyanotic, less are cyanotic. An acyanotic heart disease can be converted into cyanotic heart disease. What do you call that? there is a reversal of the shunt. There is a reversal of the shunt. Normal shunt is normal. When I say normal shunt is not normal. But when the pathology is there, whenever there is a septal defect or something, the shunt which starts from left to right side. Why left to right side? Left side generally after birth the pressure will be more. So from left side the blood moves to the right side. This is something phenomenal, expected. But what happens over a period of time? This shunt, which is actually starting from left to right side, turns to right to left side. This change is called Eisenmenger syndrome. This change is called Eisenmenger syndrome. Now this Eisenmenger syndrome, what happens? The shunt is taking place from right to left. When there is a right to left shunt, what will happen? There will be development of cyanosis. Now what was this patient? This patient had acyanotic heart disease. Now this patient who had acyanotic heart disease now is converted into cyanotic phenomena. This is called Eisenmenger syndrome. So I hope you understand this. So whenever you actually see a case of cyanosis, we need to assess whether it is peripheral or central. Now after that, exactly opposite, it can also be flushing. An abnormal flushing is also not good. Please try to understand if a person is extremely flushing. What is the cause of flushing? Abnormal flushing. Flushing could be because of carbon monoxide poisoning. Who can have carbon monoxide poisoning? For example, victims of burns. Okay, burn victims. For example, a theater is under fire and some of the victims are coming from that. Okay, a train is on fire, or an aircraft which has got into fire. From a closed room environment, and some people are rescued, they are susceptible to develop this carbon monoxide poisoning. Flushing, abnormal flushing is a sign of carbon monoxide poisoning. Just remember that. Okay. Yes, please. So now we move on. So we need to observe whether the patient is comfortable, whether the patient is cyanosed, whether the patient is flushed. Not only that, we also need to check for the respiratory rate. Why respiratory rate? Respiratory rate will help us to understand whether the patient is just breathless or he is also having distress. Respiratory rate helps us to differentiate only breathlessness or distress also is there. I'll explain to you later. And also we should see whether there are any clues around. Now just look at this. This doctor is looking at this patient, and not only patient, here there is a bed. On this side there may be a table. Some things will be kept on that. So some items which are kept on the table will help us to understand what kind of pathology or what kind of trouble he is going through. So without much difficulty, let us see. See here, the lips of the child are bluish in color. So here we see a case of central cyanosis. For example, if you see this child, here there is abnormal flushing. Can you see so much of flushing? It is completely hyperemic here. So this is a case of flushing, abnormal flushing. Now you see this, when this person is breathing, during inspiration, what is happening here? This is called intercostal suction. Intercostal spaces are going inside. This is called Ŵyr sign. This is called Ŵyr sign. Now I would like to describe this. For example, what is the meaning of dyspnea? What is the meaning of distress? I think in this season, we are very well aware of something called distress. COVID or something. We heard of something called respiratory distress syndrome. Dyspnea, what is the meaning of dyspnea? The word meaning of dyspnea is difficulty in breathing. Difficulty in breathing. Now here it is also described as when you are aware of your own difficulty. Please understand, sometimes a patient may be having a difficulty until unless he tells to others, we will not understand the difficulty. That's why it is called subjective awareness. subjective awareness of one's own breathing. This is called subjective awareness of one's own breathing. What is the meaning? Subjective awareness. Now I am breathing. I am taking class, but I am not aware that I am breathing until unless I concentrate. Oh yeah, I am breathing. But otherwise it is not coming to my conscious orientation. But if a person who is having breathlessness and if he is talking, then what will happen? He is not able to concentrate on the class because his concentration is majorly on his breath. So breathlessness is a subjective awareness. Please understand this one. It is a subjective awareness. That means the patient himself will understand. If he express it to others, others will understand. But distress is not like that. Distress is an objective breathing difficulty. An objective breathing difficulty. In fact, yesterday one patient was there. Okay. My son who is sitting next to me, he told that she's having some problem. I said, how do you understand? Then immediately he said, see that lady having some, she's trying to breathe very deeper. I can see her neck is moving. So now that is the first good thing that is observed. Actually, what is it, accessory muscles. Accessory muscles. When accessory muscles are used for breathing, that means the patient is already in a state of distress. Accessory muscles are being used up. Second important point is Hoover sign. Hoover sign. What is Hoover sign? There is a indrawing. If you just observe all these things, what is happening to these intercostal spaces? All these intercostal spaces are going inside in the inspiration. So this is a distress. This is a phenomenon of distress. And third important thing is there is also something called pulsus paradoxus. The presence of pulsus paradoxus will help us to understand distress. So please remember these two things. One is dyspnea, another one is distress. Dyspnea is a subjective awareness. When it becomes objective, the moment you see somebody, oh, he's having some breathing difficulty, that is not breathlessness. She or he is already in a state of distress. So now let's move on to another one. So these are the objective evidences that we may get next to the bed, some objective clues. Okay, sometimes we may find GTN spray. GTN spray is called glyceryl trinitrate spray. Okay, it's also nothing but nitroglycerin. Sublingual nitroglycerin is there, no? Sublingual nitroglycerin. In homeopathy, we have a medicine that is 𝘋𝘌𝘛𝘐𝘊 or amyl nitrosum. Amyl nitrosum and 𝘋𝘌𝘛 both are having the same chemical formula, and they are actually nothing but the nitroglycerin. And this GTN spray, if you see GTN spray, or if you see those tablets which are in the shape of a heart, you can understand that there is some problem with the heart. It gives an indirect clue. PCA machine is an analgesic machine. It is an analgesia, that is patient controlled analgesia. This machine is slowly releasing the analgesic timely. For example, every 3 hourly, every 6 hourly, every 12 hourly, it is already there. This machine will slowly inject this medicine into the body. That means the patient is having pain. So for those patients who are having pain, PCA machine will be there. So if PCA machine is there operating next to the patient's bed, that means he is suffering with the pain. If GTN spray is available or the cardiac related tablets are available, that means patient must be having angina. If sputum cup is present next to the patient's bed, that means the patient is having cough which is productive. It talks about productive cough. Never miss this sputum cup. Always open the sputum cup and see what exactly is happening. Now coming to the nebulizer. So whenever you understand a nebulizer or an oxygen mask is there, that means it indicates that the patient is having breathing difficulty. Not only breathing difficulty, sometimes even nose block. Some patients who have nose block, they take steam inhalation, or instead of steam directly they take the nebulizer. So these are the clues that we get as soon as we see these kind of things next to the patient's bed. So now coming to the stage 4. When we come to the stage 4, our examination starts in step number 4. When we come to this step, we are not bothered about the heart yet. We are now starting our examination in the hands, because hands speak so much about cardiac illnesses. Examining the hands is very, very, very important. So when it comes to the hand, the first thing that we are going to check, what is the first thing that we are going to check here? We need to inspect the hands. When you inspect the hands, the first thing is feel how warm they are. You know, naturally our hands are supposed to be warm. If they are very, very cold, it talks about poor peripheral circulation. So first of all, hands are supposed to be warm, and then you need to look for certain things. What are the things that we look for? It's very simple. First, you see for any presence of Osler's nodes, Janeway lesions, palmar erythema, nail clubbing, okay, and tobacco stains. These are the 5 things that we look for only in the cardiovascular significance. Now you see this is called as the pulp of the finger. Sometimes you may find some nodules in the pulp of the finger. When you find these nodules in the pulp of the finger, okay, and when you touch them, they are also painful. So Osler's nodes are seen in the pulp of the fingers, and they are also painful. Janeway lesions are seen in the palms. They are seen in the palms like this. Janeway lesions are seen in the palms, okay, and they are painless. You don't find any pain in them. They are painless, okay. And palmar erythema is another thing. Here there may be erythema, red lesions, and you know, sometimes the red lesions, generally initially they will be fully red, but what happens, you know, after some time the center will be cleared, only periphery will be present. Any name for this? Anybody speaking to me on the chat? What do you call this? Okay, this is called erythema marginatum. So what happened? Initially, it started like a red patch. Okay. Afterwards, what happened? The periphery is available, but center got cleared. When the center got cleared, we call it as erythema marginatum. And now the most important thing, look at this. This is nail clubbing. When somebody is having nail clubbing, we talk only about the cardiovascular causes. Cardiovascular cause, most important thing is bacterial endocarditis. Please remember, bacterial endocarditis is the most important cause for nail clubbing. This bacterial endocarditis, 2 types are there. One is acute bacterial endocarditis. Another one is subacute bacterial endocarditis. What is acute bacterial endocarditis? Heart is healthy. On a healthy heart, bacteria is attacking. Bacteria is attacking a healthy heart. Now then, if you develop endocarditis, it's called acute bacterial endocarditis. Here, heart is unhealthy. That means patient is already having some primordial heart condition. What is that primordial heart condition? Maybe a valvular disease, maybe a septal defect, maybe PDA, patent ductus arteriosus, or patient is already having a prosthetic valve. That means his heart valves are already replaced. Now, such patient, if you get a bacterial attack, that patients are called subacute bacterial endocarditis, which is more dangerous. As you know, already he is deceased, and on that bacterial, this is more related to the death. You know, one of the most commonest cause of bacterial endocarditis is needle sharing habit. You all understand what is needle sharing habit, okay? It is the intravenous drug abuse. IV drug abuse is one of the most important cause for the bacterial endocarditis. That's more theoretical, but anyway, let's not discuss more on that. So these are the important things. And coming to something very, very important, which we don't mind generally, this is called tobacco smoking. Why it is important for us to note tobacco smoking? Because most of the fellows, they deny their habit of smoking. Tobacco smoking results in stains. Thank God. It gives some clues. Okay. What are the clues that we get on the fingers? Particularly how they hold, that index and middle finger in between. Here they get that burnt stain because of the heat of the cigarette or the BD, what they are holding. There will be staining here. Okay. That you can see. And also on the nails. So not only on the fingers, you get these stains on the nails. And anyway, right now we are talking about hands. You can also get these tobacco stains on the forehead, teeth, okay, and lips, okay. Sometimes entire face, particularly the cheeks, okay, they get darker and darker, okay, because of the smoke continuously on the face. So this tobacco smoking is an indirect evidence that the patient is a smoker. What is the evidence of alcoholism, chronic alcoholism? Anybody would like to type it in the chat box? I would like to see chronic alcoholism. Some patients, you are practicing in Kerala, so you make it many patients like this. They deny that I'm not an alcoholic, they say. But if you want to identify, how do you identify a patient with chronic alcoholism? You can put it in the chat box. I would love to see your answers. I will tell this in the end. Before that, I wanted to see. Wow, somebody already answered. It's parotid swelling. That's correct. That's the correct answer. So now please understand, it is painless parotid swelling. Generally we see parotiditis whenever there is mumps or anything, any kind of parotid swelling is very painful. You know that there is something called as parotid fascia. There is a kind of deep fascia which is actually covering the parotid gland. It is running from the zygomatic arch down like this. Okay. Now, whenever there is a swelling, what happens? It stretches this fascia. When it stretches this fascia, it is very, very painful. That's why mumps is very painful. But here in alcoholism, there is a gradual hypertrophy of the parotid gland. Very, very slowly, there is a hypertrophy is taking place. Now you understand, when the parotid gland is undergoing that hypertrophy, because it's undergoing gradually, the fascia is also getting stretched slowly, so that what happens, these receptors get adjusted, and so it will not produce any pain. It is a bad thing, If it would have produced pain, many would have stopped alcohol much early. But anyway, it doesn't produce much, but it's helpful for us to understand that alcoholism. Anyway, very good. Okay, let's move on now. So the next stage of cardiovascular examination, see, this method will never allow us to forget the things. In step 4, we are actually starting our examination proper. In step 4, what we did examination of the fingers. Okay. Once the fingers are over, we are coming to the next step, that is radial pulse. We have to check the radial pulse. Take the radial pulse. And when you are taking the radial pulse, you should remember 2 things. One is rate, rhythm. Another one is character. But radial pulse is not an ideal pulse for checking the character of pulse. Let me make it very, very, very clear to you. Most of the time when we are studying physiology, we talk about all the aspects from the radial pulse, but we can check, but it is not ideal. Which is the ideal pulse for noting the character of the pulse? The character of the pulse can be noticed. Okay, somebody already messaged in the chat box. Let me test it. I love to get the answers. Very good. Carotid pulse. Okay, I will keep the chat box open. Yeah, carotid pulse is the ideal pulse. If you want to check the character of the pulse, it is the carotid pulse which actually helps you. So remember, it doesn't end here. We also need to go for checking the collapsing pulse. Collapsing pulse is actually seen. Collapsing pulse is actually felt in the radial pulse only. Okay, radial pulse is the ideal pulse for collapsing pulse. And remember, before you check for the, I will take you here. See this. Now, what is happening? You are not checking by your regular method here. You are actually closing the radial pulse with your entire palm like this. And suddenly you are lifting the shoulder and your arm above the heart level. Suddenly, in a brisk way. So that what happens when you experience the tapping nature, it is exactly described as when a lead ball is falling in a vacuum. When a lead ball is falling in a vacuum, it falls very slowly. But when it touches this end of the thumb, it actually gives a typical feeling. This kind of feeling, it's called tapping, which is felt in the center of the palm. Tapping, which is felt in the center of the palm when you raise it above the chest level. This is called collapsing pulse. Collapsing pulse, generally we think that it is seen in aortic regurgitation. But aortic regurgitation is not the only cause. Aortic regurgitation is not the only cause. Aortic regurgitation and all other conditions where there is a high stroke volume. Whenever the stroke volume is high, in those conditions we see this collapsing pulse. But many a times one thing student ignores, that is what for example, if your patient is having a frozen shoulder or is having adhesive capsulitis. Adhesive capsulitis and frozen shoulder are not different. Adhesive capsulitis is the medical term for a layman's frozen shoulder. Layman's term, frozen shoulder. Generally in the OPDs and all, we see students writing frozen shoulder. Frozen shoulder is just a very late term. The medical name for it is adhesive capsulitis, or the patient is having rotator cuff problem, or just imagine patient is having simple osteoarthritis of the shoulder joint. Now, for him to do his regular activity is only so difficult. But if you suddenly, without asking him, suddenly if you lift the hand like this, he will experience extreme amounts of pain. Are you with me? So what you should do before you check the collapsing pulse, please confirm he doesn't have any problem in his shoulder. It is very, very essential, because when you are a clinician, when you are actually going for clinical examination, you are supposed to be very sensitive, you are supposed to be very gentle, and you are also supposed to be very predictive. You should know what can happen because of your procedure. Okay, so with all these things, when you move forward, you will become a very good clinician. So collapsing pulse, you need to check. How to check the collapsing pulse also, but before checking the collapsing pulse, on that side, whether there is any shoulder pain, whether there is any shoulder restriction, whether there is any arthritis associated on that side is very important. Otherwise, what happens? We are doing a big mistake by creating a lot of pain for the patient. And always remember, this is the best way to check the radial pulse. Rest the arm on the patient's body or on the bed and then check the radial pulse. Never take the patient's hand into your hand, okay, and then you check it. Okay, that is wrong. Okay, remember to check that the patient doesn't have any problems with their shoulder. Locate the radial pulse and place your palm over it. Then raise the arm above the patient's head. A collapsing pulse will present as a knocking on your palm. It is not felt on your fingers, but it will be felt in your palm. That's very essential to know. Okay, now I would like to just give here, you can actually take this. Oh, sorry. Yeah, you can actually look at this. This is important. What are the other causes of collapsing pulse? Collapsing pulse can be seen in chronic aortic regurgitation. That is what generally everybody knows. But also in patent ductus arteriosus, arteriovenous shunt. This is actually true collapsing pulse. But also it can be seen in hyperdynamic circulation. When you talk about hyperdynamic circulation, we are actually talking about conditions with high stroke volume. Conditions with high stroke volume. So these are the things. After exercise, thyrotoxicosis, sepsis, severe anemia. I will put a star mark here. Okay, severe anemia, liver cirrhosis, pregnancy. I think they have forgot one more condition, that is called fever. Fever is a hyperdynamic state. Okay, fever, sepsis, pregnancy, all these are very close friends. In all these conditions, so many things are there which can happen. Can you give me one more condition which happens in all these conditions after exercise? Thyrotoxicosis, sepsis, very severe anemia, liver cirrhosis, pregnancy, fever. Any other condition which can be associated? Anything? Okay. You understand? In all these patients, we also see something called as flow murmur. All these examples are good for flow murmur. In thyrotoxicosis, you get a flow murmur, sepsis, severe anemia, liver cirrhosis, pregnancy fever. In all these conditions, you get a flow murmur. All these things are also good examples for one more thing, that is high output failure. Okay, even in high output failure, it is possible in all these conditions. So anyway, that's something nice to know. That's all. Okay. Any questions still here? Okay, we'll move. Yeah, next in the step 6. So where are we? We started with our fingers, then we went to radial pulse, that is 5th point. Now we are coming to 6th point, that is the elbows. Elbow is very, very essential. Why? Because I'm going to tell you in just 1 minute here. Just concentrate here. Elbow, sometimes we may find like this papules. This kind of papules we can see when you examine the elbow. They are called xanthomata. They are called xanthomata. Okay, you may find warts or anything, but that is not related to cardiovascular system. Why I am explaining this one to you? Because xanthomata is having cardiovascular significance. Why? Because xanthomata is nothing but deposition of yellowish cholesterol rich material that can appear anywhere in the body in various disease states. They are cutaneous manifestations of lipidosis, in which lipids accumulate in large foam cells within the skin. They are associated with hyperlipidemias. Now I am telling you, dear friends, if you find somebody having, just a minute, I'll annotate it. Okay, can you see this here? You can find papules here. You can find papules here. Okay, you can find papules here. These are nothing but deposition of cholesterol foam cells under the skin. Now, if you find this, you can directly understand that this patient may be suffering with something called hyperlipidemia. Is it good or bad? Just by observation itself. You know, for some years, I used to give this question to my students. What are the objective evidences? What are the objective evidences of dyslipidemia? You know, most of the time students' answer will be obesity. That's not correct. Obesity is not a correct answer. Many obese individuals may have absolutely perfect lipid levels. Okay, objective evidence of dyslipidemia is xanthomata. Another one is xanthelasma. You must have heard of xanthelasma. Around the eye, cholesterol pockets may develop. Another one is corneal arcus. Corneal arcus is also another good example of dyslipidemia because of excess lipid that is getting accumulated around the cornea, cholesterol granules they call it. Okay, so this is called xanthomata. Any questions? No questions. Okay, so this is xanthomata. So the moment you see xanthomata, you understand that the patient may be having hyperlipidemia. Now you see I've got something else for you. This xanthomata can be present not only on the elbow, sometimes on the knee also. Okay, now if you find this cholesterol pockets, can you see this? They may grow very big sometimes. They just look like tumors. This is called xanthelasma. There is one more variety in the tendons, cholesterol getting deposited in the tendons. That is called xanthoma tendinosum. Xanthoma tendinosum. These are the cholesterol. But at the same time, let me also tell you this one. Many times patients will have xanthelasma, but when you check the cholesterol, it will be perfectly normal. Okay, so need not be all the patients who have xanthelasma that they have the hypercholesterolemia, but it is a good point to be suspicious. The moment you see xanthelasma, the moment you see xanthomata, you can be suspicious about hyperlipidemia. Checking this is always good. Just like if you find acanthosis nigricans, a dark color and also a lot of skin tags, it is better to check for diabetes. It is because it is an objective evidence we are getting of what is it called, insulin resistance. Just like that, if you find xanthomata in the skin, if you find xanthelasma around the eyes, or if you find xanthoma tendinosum, it is better to check for their cholesterol levels because it can be abnormal. Now we going to the point number 7 here. When we are going to the point number 7, we understand. Again, I'm telling you, first we started with point number 4 in the fingers and then in the palms. Then we went to radial pulse. After that, we are going to check the blood pressure. Okay, there is nothing much. Point 7 is actually about the blood pressure. You should measure the blood pressure. Then we are going to point 8. See, from after measuring the blood pressure, straight away we are going to the face, examination of the face. Face gives so many points about cardiovascular pathology. So you should not ignore the signs that is associated with the face. Okay, so when you go to the examination of the face, it's the first thing that we examine is the eyes. When you look at the eyes, for example, when you are looking at the eyes, what is the first thing that we see here? What is the first thing that we see here? The upper bulbar conjunctiva. Okay, for that I would like to give this. Many times students have confusion about this. Okay, I think I will show it in the picture form so that you will understand. So okay, anyway, we got this. So upper bulbar conjunctiva, we need to look for the icterus. Icterus is actually found in the upper bulbar conjunctiva. No, not that it is found only in the upper bulbar, it will be found in lower bulbar also everywhere. But upper bulbar conjunctiva is very, the surface area is more. So it is easy for us to pick it up. That's why it is told, always ask the patient to look downwards and then lift this upper eyelid upwards. And then you can visualize the upper bulbar conjunctiva. And then if it is yellowish discoloration, particularly lemon yellow, okay, then we know that the patient is having icterus. Whereas lower bulbar conjunctiva, somebody is annotating other than me. Can you please stop it, because it is disturbing. Okay, please don't annotate on the screen. Yeah, 𝘔𝘌𝘛𝘏𝘖𝘋S, please don't annotate on the screen, please. Thank you. Yeah, so now once the upper bulbar conjunctiva is examined, then we need to go for lower bulbar conjunctiva. Lower bulbar conjunctiva is generally used for pallor, because lower bulbar it is lower palpebral. I correct myself. It is not bulbar, it is lower palpebral conjunctiva. It's a mistake of copy paste. Okay, so it is lower palpebral conjunctiva. When you see lower palpebral, means the conjunctiva that is present inside the lid. That is the area where we check for the pallor. Then we should always look for the corneal arcus. Corneal arcus is different from senile arcus. I'm going to explain to you in a few minutes. And then xanthelasma. We need to look for xanthelasma. Now, since we are talking everything in relation to cardiovascular system, is icterus something to do with cardiovascular system? Anybody? You can put it in the chat box. A patient who is suffering with jaundice, will he have any cardiovascular manifestations? Jaundice means the patient is having excess bilirubin. That's why it is called hyperbilirubinemia. Hyperbilirubinemia. Excellent. Somebody said right heart failure. Absolutely. Okay. But one more thing is obstructive jaundice. Please remember this also. If a patient has obstructive jaundice, patients with obstructive jaundice can present with bradycardia. You know, we are actually looking at the ECG, we are looking at the heart, we are looking at electrolytes. Everything is absolutely fine, but still there is no explanation for the bradycardia for the patients. Now, this bradycardia could be just because of obstructive jaundice, because in obstructive jaundice, because of the bilirubin levels are increasing. This bilirubin can suppress the SA node, and that can produce bradycardia. Okay, yes, very good. So now let's move on. I will show you some pictures. Now I want you to carefully see. I'm looking at your chat box for the answer immediately. Is there any difference here? Can you find any difference between these two pictures? Now here we see that the patient's skin is yellow, his face is yellow, palms are yellow, sclera is also yellow. But here we find his palms are yellowish or orangish, face is also dusky orangish, but eyes are perfectly fine. Eyes are perfectly fine. Excellent, Dr. Nasla. Okay, it is carotenemia. This is a case of carotenemia. Now you know that Carotenemia is excess amount of beta carotene in the body. Now, carotenemia is also another important DD, differential diagnosis for icterus, not only jaundice. Carotenemia is also one of the DD for icterus. But how to differentiate that? The bilirubin has affinity. Bilirubin has affinity for the collagen here in the eye. That's why bilirubin stains the collagen of the eye. That's why the sclera becomes yellowish. But whereas this eye, the sclera here is not, it is not having any affinity for beta carotene. That's why beta carotene cannot stain the sclera, but it can stain the skin, it can stain the palm. So remember, if the patient, you know, this orangish and yellowish, no, in Indian skin, we cannot differentiate greatly. But the only differentiating point is, if the sclera is also yellow, it is going to be jaundice. If the sclera is not yellow, all the parts of the body are becoming yellowish or orangish, then it could be carotenemia. Carotenemia can happen because of certain drugs. Okay, certain drugs can cause this, and sometimes some food like beetroots, carrots, excess consumption, or some fruits also. Okay, so that's a point here. Good, somebody is answering very well. Okay, now another thing here, see this. This is above the cornea. Now this part is called as the bulbar conjunctiva. This is called upper bulbar conjunctiva. Okay. Now here you see, this is a lower bulbar conjunctiva. But most important thing for checking the pallor is this conjunctiva. I would like to annotate here and show you. See this. This part. This part becomes very, very essential for us. This is the lower palpebral conjunctiva, and this is the upper bulbar conjunctiva. You see how beautifully lemon yellow it is, upper bulbar conjunctiva. So this is the thing. Okay. Yes. Now you see this. There are small differences between senile arcus and corneal arcus. Now you see this. The senile arcus is seen. The reference for this is MacLeod's. Many times when I tell the students, they ask me, and one edition older, probably in the 13th edition, you get this answer. If the patient's age is above 50, if the patient age is above 50, we can use the term senile arcus. But corneal arcus is if the patient age is less than 50, if the patient age is less than 50, we use the term corneal arcus. Corneal arcus is yellowish. Corneal arcus is yellowish. See this? It is yellowish in nature. And what is the reason? Hyperlipidemia. Hyperlipidemia. Just initial few pages when you read in the MacLeod's for cardiovascular system examination, you will find this point. So it is hyperlipidemia. Hyperlipidemia, yellowish crystals deposition around the cornea. Patient's age will be less than 50. But here, in case of senile arcus, it is cloudy, silvery. Okay, this is a description, cloudy and silvery, and patient's age will be more than 50 years. This is what we call it as senile arcus. So if I ask a question right now, what are the objective evidences of hyperlipidemia? What are the objective evidence of hyperlipidemia? You can simply say xanthelasma, xanthomata, and corneal arcus. Okay, these are the three important objective evidences. That means if the patient is having a hyperlipidemia, he will have one of the thing, or sometime all the three of the thing, or sometime may not have any of the things also. Okay, but these are the objective evidences. So clear, I suppose. So let's move on now to the next one, that is the examination of the mouth. Okay, here complete face. Now eyes are over. Now we go to the mouth. Okay, examination of the face. First we come to the mouth. Anemia and glossitis. These are the important things we need to look for. If the gums are the first evidences. You know, when somebody smile, pale gums, it's a very important sign of anemia. Sometimes tongue also, and under surface of the tongue also sometimes can be pale in color. Glossitis, very red tongue. Sometimes they call beefy tongue. Okay, so this is a strawberry tongue. Okay, any of the thing. Glossitis, where there is inflammation of the tongue, there is the red tongue. Okay, angular stomatitis, angles of the mouth are cracked. Sometimes the cracks extend and it is extremely dry, and sometimes a whitish beading will be there because of okay, I will give the name, you can type it in the chat box. It is called 𝘋𝘐𝘕. 𝘋𝘋𝘕. 𝘋𝘋𝘕 is just crack is there, not only crack. Anybody? There is a superimposed infection from yeast infection. Which is the yeast infection on the skin? Yeast infection on the skin is, okay, I will wait, no problem. I'll wait. Ah, very good. It is candida. Okay, candidal infection. It is not just angular stomatitis. It is not just angular stomatitis, but when there is a superimposed candidiasis of the crack here, that is called 𝘋𝘋𝘕. It appears as if like a pearl, beads of pearl on both sides. Okay, Google this information, you will get it. Okay, it's called 𝘋𝘋𝘕. Okay, next is, after the angular stomatitis, we need to look at the tongue for cyanosis. When tongue is cyanosed, naturally it is central cyanosis. And also look for malar phases. It is also called mitral phases. Okay, so now look at this. This is the angular stomatitis. This patient is also having cheilitis, that is, the lips are also cracked and inflamed. And here there is a glossitis, and on this side you can see cyanosed tongue. There is a cyanosed tongue. Tip of the tongue is bluish compared to the posterior part. So this is actually a cyanosed tongue, which is actually talking about some cardiovascular pathology. And now you see this man. It is a textbook says that malar flush or the mitral flush or mitral phases, it's not so common in India. Not because mitral phases is not common, because of our complexion probably. It's not that easy to understand. But see, in foreigners, it's very easy because of their color complexion. See, this is called as mitral phases or malar flush. Okay, next coming to the neck. So we have started with the fingers. Again, I remind you, we started with the fingers. We went to radial pulse. After that, we looked at the elbow for xanthoma. Then we checked the blood pressure. After the blood pressure, we came to the face. First, you saw the eyes. After that, we saw the mouth. Then we saw the malar flush. And then we are coming to the neck. When we come to the neck, the most important thing that we are supposed to do here is jugular venous pulsation. Patient is already in Fowler's position. There is a scale that is placed on the patient's chest exactly at the manubrosternal junction, and then another scale or anything like this can be okay. The upper level, for example, here we have the jugular vein. This is the place we have the jugular vein passing. Okay. And if the jugular vein is filled up to here, okay, that means the blood level is here. Now with this, you come here, see this 1, 2, 3 and more. It is almost 3.5. Generally speaking, you see the right atrium. If you believe this is the heart, if you believe this is the heart, this is the right atrium. This is the center of the right atrium. From the center of the right atrium till the manubrum sternum, see this? This is called 5 centimeters. It is 5 centimeters. From here, it is 2, up to 2. That means this up till here is normal. That means 5 plus 2. This from the center of the right atrium till the manubrosternal junction, this is called CVP. What is CVP? Central venous pressure. From the central venous pressure, from here to here, this is actually classically the jugular venous pressure. But most of the time, textbooks combine the CVP and JVP together. Why? Because any change in the central venous pressure immediately affect the jugular venous pressure. That's why CVP and JVP together. So they say 7 is normally the JVP. 7 is the pressure in JVP. So when you say 7 is the JVP, it is actually a combination of central venous pressure and jugular venous pressure. Is it clear to you? So now what is happening? It is more than 7, 3.5 it is. 3.5 means 5 plus 3.5. It is 8.5. 8.5 more. That means in this patient, JVP is elevated. So when JVP is elevated, the problem is in the right heart. The problem is in the right heart. Either the pathology is in the right atrium, or the pathology is in the right ventricle, or the pathology is in the, what is it called? Yeah, tricuspid valve, or sometimes pulmonary valve, or sometimes the problem may not be there in the right atrium or anywhere. The problem is directly in the pulmonary circulation. That is called pulmonary arterial hypertension. In all these conditions, the patient can have elevated JVP. If the problem is not in the right heart, still the patient is having increased JVP. That could be because of obstruction. Now you see this. This is the superior vena cava and this is the right atrium. This is the right ventricle. Now just imagine here is the pulmonary valve. This is the tricuspid valve. Now just believe that here there is an obstruction. Okay, small obstruction is there. So what will happen? The blood that is trying to come down is not able to come down. Everything is moving upwards only. Okay, because of this, what happens? JVP is elevated. So which is one pathology which is not affecting the heart, but still there is a elevated JVP. That is superior vena cava obstruction. Whenever there is a superior vena cava obstruction, still the JVP is elevated. It is a non-cardiac cause of elevated JVP. A non-cardiac cause of elevated JVP. So many other causes are there, non-cardiac. That means whenever there is a hypervolemia, still the patient can have this one. So in our tomorrow session, again, I will just highlight a little bit about this JVP also. Yeah, so we need to do the neck examination. JVP assessment is very important. Hepatojugular reflex. What is this hepatojugular reflex? Hepatojugular reflex, yeah. So here, hepatojugular, we are giving a gentle pressure on the abdomen, particularly in the right hypochondrium. When you are giving a gentle pressure in the right hypochondrium, please remember, we need to inform the patient. It may be slightly painful. Okay, and then when you just give a gentle pressure, what happens? Because the liver is compressed, the inferior vena cava is also compressed, and when the inferior vena cava is compressed, there is a reflex that happens to the right atrium, the blood entering into the right atrium, and that blood which is entering into the right atrium is now again pushed upwards, and so naturally the JVP will be elevated. And now for every person, even in healthy person, what happens when you give a pressure? Suddenly, this jugular venous pulsations may be visible. But you know what happens? After some time, even if you are still holding it here, they will disappear. If it is sustained. If it is sustained for more than a minute, then we need to understand there is a cardiac pathology. So please understand, dear friends, hepatojugular reflex is normal to healthy individuals also. But what happens over less than a minute? What happens? The pulsations will disappear. But if it is sustained more than a minute, then we need to understand there is a right heart pathology. I hope you understood this. Let's move to the next one. I have just got one GIF here. You can see here the jugular vein is pulsating abnormally. You can actually look at your friends or your parents here. There will be no pulsations here. You see this? So beautifully the jugular vein is being pulsated. So tomorrow we will start with this only. I would like to speak a little more about this JVP. We'll start with this. So here, if you give a compression, what happens? It starts filling from below upwards. This is about the jugular venous. So all these 10 points, we have spoken only about the peripheral examination findings of cardiovascular system. Tomorrow's session, we are going to straight away land upon the cardiac examination. That means first we will talk about precordial examination. After precordial examination, we will talk about the inspection, palpation, auscultation. The three important steps in approaching the cardiovascular pathology. So tomorrow's session, I'll be giving little bit of basic physiology about the heart zones also, and then we'll start on the examination findings. So I think with this, we can close today's session. If you have any questions, I'm available to you for 2 minutes, so you can ask those questions. Yeah, by the time you think about the questions, let me just revise what we have done here today. I told you first the examination starts in the fingers. Okay, clubbing is important. Osler's nodes, Janeway lesions, erythema marginatum, or sometimes palmar erythema is important. Then also clubbing we have to see. Then radial pulse is important. Radial pulse is not the ideal pulse for character. You need to check the carotids for the character. Then collapsing pulse is checked here. Remember about the shoulder pain for the patient. Then looking for the elbow for any xanthomata. If xanthomata are there, that means hyperlipidemia can be there. Then check for blood pressure. After that, go to the face, look into the eyes. Then the C for icterus, pallor, then xanthoma. Okay. After that, corneal arcus. Coming to the mouth, checking for pallor, also for cyanosis. It's important. Angular stomatitis. Once mouth is over, malar flushing is important. It is seen in case of mitral stenosis. Then coming into the neck, we have to check for the jugular venous pulsations and jugular venous pressure. So this is what we have covered. Peripheral examination actually gives more clues about cardiovascular pathology. We are not supposed to ignore it. And in the next session, we are talking about precordial examination completely. That is tomorrow. Okay. Yes, please. I think Dr. Deepu, we can close it here.
Yeah, please.
Yes.
Is there any questions are there? Sir, just a moment. Huh?
Yes, please.
On behalf of our SHABDHIKA College Union, SVR HMC Unit, Academic Club and whole college, I extend a really hearty vote of thanks to Dr. G. Rajachandra sir, who took the first session of our webinar series. Today, we had an amazing opportunity to hear your thoughts and knowledge about how to approach a cardiovascular patient. It gives deep insights to examining a patient step by step. Thank you so much, sir.
Thank you.
This session will surely be going to encourage us in our future events. Also, I'd like to thank Dr. Deepu sir, who and our technical assistants, Dr. Russell sir, who provide the faculties for our sessions. Thank you, sir. Finally, I'd like to place my hearty thanks to all the volunteers and participators, because of whom we made this possible. Thank you, everyone. And also, everyone, please join the next session on time.